Spine and lower limb neurological examination. So I'm watching my hands, introduce myself, nice to meet you. So, okay if I examine your lumbar spine and lower limb? Okie dokie. First thing I'm going to do is get the patient appropriately exposed. I'm going to have a look at the patient from the front and from the side and from the back. I'm going to observe the three natural curvatures of the spine, those being cervical lordosis, thoracic kyphosis and lumbar lordosis. When I stand around the back of the patient, I'm going to look for any scoliosis that may be present, any cafe LA spots which may indicate neurofibromatosis, and any hairy patches which may indicate spinal bifida, or any lumpy bits sticking out, which could be a gibbous, which is possibly a spondylolisthesis going on there. Equal dimples of Venus, I would hope to see. Equal skin folds across L4, and normal gluteal and muscle bulk in the lower limbs. Okay, that'll be the look. Okay, from a feel point of view, I'll start mid-thoracic spine, feeling down the spinous processes. Feeling all the way down, any tenderness? No. Okay, feeling to the top of the sacrum. Okay, no tenderness there. I'm going to feel the paraspinal muscles all the way down as well. No pain there?
No.
Okay, good. Right, okay. Then we'll do movement. So, to see if the patient's lumbar spine is flexing, what you can do is stick two fingers on the lumbar spine like this and ask the patient to bend down and touch his toes. And what you should see is your fingers should spread apart a little bit, which they are. Okay, did you capture that? Okay. So I'll test the lumbar spine movement. So it's at least we know it's flexing. Okay. Can you turn to face me, please? Okay. How can you reach down the side of that? Flexion, lateral flexion, good. To lateral flexion like that, good. And can you back as well? Extension, good. So we've got some plenty of movement there, none of which caused any pain. So that'll be the look, and we're doing the feel, and that's the movement. Okay. Now we're going to do tone, power, and reflexes. And now the couch please. Okay, so lower limb muscle tone can be assessed again by grossly just doing some internal and external rotation. Now that's fine. Okay, take the limbs through the passive range of motion. Okay, no pain when we do any of this, and the muscle tone feels fine. Again, muscle tone can either be decreased, normal, or increased. It would be likely to be decreased in lower motor neuron problems and increased in upper motor neuron problems. Okay, so that's the tone. I'm now going to do, I'm going to test the power in your lower limb. Okay, so I'd like you to just hold it there for me, please, and don't let me move it. Okay, good, that's hip flexion. Don't let me move it again. Good, that's hip extension. You keep it there for me, please, and don't let me move it. It's knee extension. Don't let me move it again. Knee flexion, good. Relax your leg now. Keep your foot there, don't let me move it. Don't let me move it. It's foot dorsiflexion, don't let me move it. It's foot plantar flexion, don't let me move it. It's eversion, don't let me move it. It's inversion. Okay. Tone, power, reflexes. Okay, now we're going to do knee jerk reflex. Okay. That's 1, 2. Okay, that was a little bit more brisk than that one. Okay, we'll judge you by the company it keeps. Ankle jerk. Okay, you strike the Achilles tendon with a foot and a little bit of dorsiflexion, so it's under a little bit of tension. Nice and relaxed there. Okay, that's 1. Again. Yep, got them both there, good. If I wanted to do the Babinski reflex, the way to do it would be to scratch the foot using the sharp bit of the tendon hammer up the outside of the foot and work towards the great toe. It would be normal for the foot to curl downwards, and it would be abnormal for it to go upwards and the toes to split out. Okay. Yeah, there we go. Now I'm going to test the lower limb sensation, and with your eyes open, just so that you know, this is sharp and this is soft.
Yeah. Can I just stop for a second? On my legs, you probably have to go quite hard with that hard one.
Okay. Right. Okay. So I'm just going to do a sensation. I'm going to do sharp first. So I just want you to close your eyes and you say yes if you can feel me touching you. L1.
Yeah. Yeah.
L2.
Yeah. Yeah.
L3.
Yeah. Yeah.
L4.
Yes. Yes.
L5.
Yes. Yes.
S1.
Yes. Yes.
Okay. That's the same and normal and equal for you, yeah?
Mm-hmm.
Okay. I'm now going to test soft sensation. Okay, I want you to tell me if say yes if you can feel me touching you, and if it's normal for you. Okay?
Yes.
L1.
Yes.
L2.
Yes. Yes.
L3.
Yes. Yes.
L4.
Yes. Yes.
L5.
Yes. Yes.
S1.
Yes. Yes.
Okay. Now I'm going to touch your lower limbs in any particular order, and I want you to tell me whether it's sharp or soft. Okay?
Sharp. Soft. Sharp. Soft. Sharp. Soft. Soft.
It's going to test your coordination now. What I'd like you to do is to repeatedly rub this heel down this shin. As quick as you can, see if you can do that for me. Okay, what I'd like you to do is take it down the end, lift it off, and then put it back on. Down your shin, that's it. You do it with your eyes open, that's all. Yeah. Good. On the other side. Lift it off. Good. Excellent. Okay, vibratory sense. Again, the 128 hertz tuning fork on the distal interphalangeal joint. Okay, can you feel that vibrating?
Yep.
Tell me when it stops.
Stopped.
Okay, and again. Can you feel that vibrating?
I can.
Tell me when it stops.
Stopped.
Okay, good. If he was unable to feel it, I would just move more proximal until he could, and I'd map it out thus. I'm not going to test your lower limb proprioception for for dysdiadochokinesia. I'd like you to tap my hands with your feet as quick as you can. He's able to do that. His cerebellum is able to differentiate between two antagonizing muscle groups. Excellent. Thanks, John. Good. Okay. I'm not going to test John's proprioception again. I'm going to immobilize the middle phalanx. Okay. Okay, John, that's down and that's up. Can you close your eyes for me, please? Okay. I'd like you to tell me where I leave your toe.
Down. Up.
Same again.
Up. Up.
Okay, good. We'll do a quick test for ankle clonus. Okay, to test for ankle clonus, okay, this can be a sign of cervical myelopathy or upper motor neuron lesions. Again, you get the lower limb nicely relaxed, and then you quickly dorsiflex the ankle. Okay, and if the patient had clonus, they would have several repeated beats of plantar flexion, and here there's none at all. Okay, good. So with your patient in this position, you can test the sensation of S1, S2, and if you wanted to S3, S4, and S5. But we'll take that as stated in the textbook. To do a femoral nerve stretch test, you passively extend the hip off the bed. Okay. No pain in there?
No.
Okay. Pain in the anterior thigh would be possibly indicative of lesion of L2, 3, or 4. Right, I'm going to briefly go through Waddell signs. If the patient has 3 or more of the Waddell signs, it's a sign that the patient sort of needs some further investigation, because Waddell signs are indicative of a possible cause of non-organic back pain. Okay, some of the signs are in fact, if you were testing a sensation of the patient had an exaggerated response to very, very light touch that wouldn't actually cause the pain. This would be one of the signs. Okay. Another sign would be axial loading of the spine. Can you stand up for us, please, John? Okay. Okay. Axial loading of the spine is. Can you tell me if this increases your lumbar spine pain? This is only for lumbar spine. Okay. You gently press on top of the patient's head, and this should not exacerbate lumbar spine pain. If the patient says it does, then it's another one of the Waddell signs. Pseudo rotation of the spine as well is another one. Can you put your hands on your hips for me, please? So I'm going to stand behind you. I'm just going to rotate you from side to side. And when you rotate the patient like this, holding onto the hips quite firmly, you're actually rotating the hip joints and not the spine. This is pseudo rotation of the spine. If the patient complains that this increases the lumbar spine pain, that'll be another one of the Waddell signs. Another one is distracted straight leg raising. With the patient sat on the bed, could you just sit on the bed normally for us, please?
Fine down.
That's fine. Okay. You would ask the patient if you could look at the bottom of the foot. Can I have a look at the bottom of your foot? And you'd be mindful, whilst you're doing this, that the patient is actually has the hip flexed to about 90 degrees and is able to achieve, in this instance, almost 90 degrees of flexion with the leg straight. So this tells me that when we lay the patient down, it should be able to get to nearly 90 degrees. So if this isn't causing me any back pain because I'm distracting him, I'm looking at the sole of his foot. Can you lay down for us, please? Okay. When we do straight leg raise, you should be able to get to the same point. Okay, which you can. You've got some tightness in the back of your leg here now. Yeah, but you've got no back pain and it's not radiating down past your knee.
No.
Okay, so you can almost get to 90 degrees like he could when he was sitting. If he was getting pain at this level, that will be another one of the Waddell signs, which is a cause of non-organic pain. The last Waddell signs would be non-anatomic or dermatomal distribution of altered sensation in a glove or a stocking distribution as well. If you had if you mapped it out and it crossed several dermatomes and stopped at a well-defined point on one limb, that will be another one of the Waddell signs. So 3 of the 5 would be indicative of further sympathetic exploration of the patient's symptoms. Okay, I'll get the patient to walk as well for us, please. Looking at his gait is normal. You can turn around and walk back. On your heels, can you walk on your heels? Heels for L5, good. And you turn around and walk on your toes, S1. Okay, there's no weakness there. Good. Thank you very much indeed for letting me examine you.